Finally, we turn to the red blood cell indices, which help us go beyond just counting cells, as these indices describe red cell size and hemoglobin content. They are essential for classifying types of anemia. They include mean corpuscular volume, MCV, mean corpuscular hemoglobin, MCH, mean corpuscular hemoglobin concentration, MCHC, and red cell distribution width, or RDW. Together, these parameters allow us to distinguish between microcytic, normocytic, and macrocytic anemias, as well as hypochromic versus normochromic cells, which are key tools in forming a differential diagnosis. Taking a step back, red blood cell indices give us a deeper understanding of a cell characteristic. They describe the size of red blood cells and their hemoglobin content, which helps us classify types of anemia. These indices are calculated from relationships between hematocrit, hemoglobin, and red blood cell counts, using mathematical formulas. The system was first developed by Maxwell Weintraub in 1934 and remains the foundation for anemia classification today. By interpreting these indices, we can quickly determine whether a patient's anemia is microcytic, normocytic, or macrocytic, and whether cells are hypo or normochromic, which provides a much more clear clinical picture. The normal ranges for red blood cell indices vary by age. For MCV, adults and children typically fall between 80 to 95 femtoliters, while newborns are slightly higher. MCH is normally 27 to 31 picograms in adults and a much tighter range in newborns. Mean corpuscular hemoglobin concentration, or MCHC, is fairly stable, 32 to 36 grams per deciliter in adults. And finally, red cell distribution width, or RDW, is normally 11 to 14.5%. This gives us some baselines when we're looking at these different types. The main use of RBC indices is to classify anemia, as they provide information on cell size, hemoglobin content, and hemoglobin concentration, which point towards different causes. For instance, MCV and RDW tell us about size variation and can help distinguish between the micro, normo, or macrocytic anemias. MCH provides information about average hemoglobin per cell, while MCHC reflects the concentration of hemoglobin inside each cell. Together, these indices allow us to move beyond knowing that anemia is present to forming a clear differential diagnosis. Mean corpuscular volume reflects the average size of a red blood cell. If it's high, we call the cells macrocytic, and if it's low, we call them microcytic. Macrocytosis often points to vitamin B12 or folate deficiency, while microcytosis suggests iron deficiency or thalassemia. Normocytic values can still indicate anemia, but typically point to chronic disease, acute blood loss, or even kidney disease. This is one of the first values as a doctor you would look at when interpreting anemia. MCH, or mean corpuscular hemoglobin, measures the average amount of hemoglobin inside each red blood cell. Like MCV, it can help classify anemias into macro or microcytic patterns. Larger cells typically contain more hemoglobin, so a higher MCH value is expected. Smaller cells contain less, so a lower value appears with more microcytic anemias. It doesn't always provide unique information, but it can reinforce an MCV finding. MCHC reflects the average concentration of hemoglobin within a single red blood cell. If it's low, we call cells hypochromic because they look pale on a peripheral smear due to less hemoglobin. This is seen in iron deficiency and thalassemia. MCHC, if normal, we call those cells normochromic. This is common in anemia of chronic disease. And it's interesting because MCHC cannot be hyperchromic because there's a physical limit to how much hemoglobin can fit inside a red blood cell, which is about 37 grams per deciliter. The RDW measures the variation in red blood cell size, which is a feature called anisocytosis. A high RDW means the red cells are of many different sizes, while normal RDW suggests uniformity. This is really helpful in diagnosing anemia. For example, iron deficiency anemia often shows increased RDW because the marrow is producing both small iron deficient cells and newer cells of different sizes. On the other hand, thalassemia often has a low MCV, but a normal RDW because the cells are uniformly small. RDW therefore adds another layer of nuance for classification. There are several things that can interfere with RBC indices. Things like abnormal cell sizes can skew the results of MCH and MCHC. Elevated white blood cells can make MCV and MCH appear falsely elevated. Reticulocytes, which are larger than mature RBCs, can also increase MCV. High lipid levels in the blood can falsely raise hemoglobin, MCV, and MCH. And cold agglutinins may cause clumping that elevates indices artificially. There are drugs that can also raise MCV, and these are all important considerations when interpreting an unusual pattern. Like the rest of the CBC, there's no fasting required, and blood is collected in a lavender tube with EDTA. When we come back, we will just go through a few kind of rapid fire causes for increases or decreases or changes to these red blood cell indices.